Hello, everyone. Today we are at week 10. So pat yourselves on the back. It has been a long 10 weeks. You guys have learned so much information, and we still got some stuff to cover this evening. But we're going to go over general anesthesia. This is going to be something that you're going to be accustomed to, okay? But I also want you guys to check out the mini session if you have not already. I'm going to go ahead and put that in the chat for everyone. Make sure you go. And of course, we're going to have some little sprinkles this evening, but it still has a lot of good information. We do have a Kahoot game, and then we're going to wrap it all up. Okay. Again, we're getting closer and closer. And if you notice, the highly missed questions are getting smaller and smaller. And again, that's just because of your hard work. You guys keep it up, okay? So, chapter 14, general anesthesia. Now, here are some questions, though, from that mini session. Which of the following statements is true regarding the management of mild allergic reactions and the potential escalation to anaphylaxis? Is it A, H1 H2 receptors antagonists like Benadryl should be used for anaphylaxis as they effectively reverse severe allergic reactions? Or B, if early signs of mild allergic reactions such as skin, redness, or hives appear, potential triggers should be stopped immediately to prevent escalation of anaphylaxis. I love it. You guys are correct. It's B. It's B because in the operating room, if there's anything going on, the first thing you're going to hear is we're going to stop whatever we were doing, oxygen, whatever trigger, because at that point, we're trying to make sure that we're eliminating any potential triggers. Okay. Now, of course, A is incorrect because H1 and H2 receptor antagonists, like Benadryl, are typically used to manage, right, mild allergic reactions, and then they counteract histamine release. However, they are not the first line of treatment for anaphylaxis because remember, we are trying to kind of combat it. Now, epinephrine is the first line of treatment for anaphylaxis because it addresses both the respiratory and the cardiovascular systems of any type of severe reaction. So, good job. We're not done. We have one more. In a cardiac arrest situation during surgery, which of the following responsibilities would most likely fall under us? A, administering medications and ensuring the crash cart is stocked with necessary supplies. Or B, maintaining the sterile field, assisting the surgical team, and helping with equipment readiness for emergency use. And I am looking at the responses. And again, you are correct. It's going to be maintaining the sterile field. Now, of course, if the situation changes, you go by the situation. But our first line of anything we're doing is to maintain the sterile field. That's during hurricanes, earthquakes, you name it. When I was working the weekends at the children's hospital, we had an earthquake. And the very first thing that my goal was is to make sure nothing was going to fall on my field because as soon as the tremor stopped, the first question was, is our sterile field good? Right. So the surgeon and the circulator, they were looking at the patient, making sure that they were good. And I was kind of monitoring the sterile field. So good job, everybody. Good job. All right. Now for tonight's learning objectives. This is weird. This is almost like coming full circle, right? Because this is the last group of learning objectives for now for us. So we have to look at abbreviations related to anesthesia. We're going to list and discuss indications for why we give general anesthesia. We're going to look at the equipment. Now, keep in mind, if you're at a small surgery center or like a smaller facility, you may be required to kind of help like get the anesthesia cart turned over in between cases. So kind of like keep that in mind. We're going to look at basic components of general anesthetic, methods of inducing general anesthesia. And then, of course, this is really important. I have seen it on week 10's quiz as well as your final, where they talk about the phases of general anesthesia. We're also going to explain options for airway management and steps in the process of endotracheal intubation. I know it's a lot, but it's really, really important because this is what we're going to be dealing with, or what you guys are going to be dealing with every day. Okay. With that, it's important to know these terms. The quiz can throw different questions at you. For example, what is the term a mixture of two liquids that don't fully blend common in pharmacology? Looking at the list of terms, what would you guess that is?
I would say emulsion.
And you would be correct. Good job. Yes. And so these are some questions that may populate on the final. Now, keep in mind, we know that it's random what questions they grab, but kind of like go over it. You're still going to get your study guide will populate this evening. I know that's a little bit early, but that way you're not going to have to stress, especially if you're working over the weekend. It will be there for you. So it will be in announcements. It should open up this evening, and it's just a study guide for your final. Okay. Other things that you will hear, extubation. We do that a lot, removing the ET tube after use. Depending on the facility is when the patient will be extubated. Some go to recovery and get extubated. Some get extubated in the operating room. Okay. Lacrimation, tear production. LMAs, this is the device that we place over the larynx. This is when they are trying to open up the airway. ENT, sometimes when we're doing airway cases, us and the surgeon are doing that part, not the anesthesia. They're there just in case something happens. Like they're the ones putting the patient to sleep. They're the ones initially putting that LMA in, and then we switch it to what we need to get in to get whatever's out of the airway. And this is a lot of times in little ones. Those who of us that are parents, we know what they can put down their throat. For those of you who haven't got that experience, once you get in the operating room and you get an airway case with a little one, you'll be like, oh my goodness, they put that in their throat, they put that in their ear, they put that in their nose. And then we're going in and taking out those foreign bodies. And then the other thing I want you to remember is the maintenance phase. It begins after the airway is secured and continues until the surgery is complete. All of these terms that you see in front of you are going to be really important just to understand anesthesia, okay, especially during surgery and our responsibilities as the ST scrubbed in. But there's a little bit more terms. We have a MAC. This is measuring the concentration of inhaled anesthesia needed to prevent movement in response to an incision in 50% of patients. Now, different from a MAC in chapter 14, okay, which stands for monitored anesthesia care. This is minimum alveolar concentration. I know this is going to be one that you're going to really want to make sure you can differentiate, but you'll kind of figure it out by the way the question's asked. Okay. Drugs, opioids, natural or synthetic, they're going to produce similar effects to morphine. And then when we're done with our case, our patients are going to go to none other than the post anesthesia care unit, better known as the PACU. With pre-induction phase, this starts when the patient comes into our suites. It ends when the anesthesia is administered in the operating room. Okay, so they're coming in, pre-induction phase has started. It ends once and like they're hooked up and you can start hearing them count back from 100. Okay, with your rapid sequence induction, that's what RSI is. Let's say your patient has gastric reflux. Okay, this is going to be for patients that are at a higher risk of aspiration. Now, again, more terms just to be familiarized with. So, in the operating room, we do not want our patients to feel pain. Now, just the basics, okay? We're looking at the pain impulses, nerve endings, right? These are going to detect pain, and then they're the ones that send signals through nerves. Your nerves are going to be the pathways that kind of carry the pain signals to the spinal cord, like the highway. Like our car, we're in the car, we've got the message. In order to get where we need to go, we take the highway, which is our nerves, okay? Because our nerves are going to get us where we need to go. With sensory and motor nerves. So you have sensory nerves that are going to send the pain signals to the brain. Motor nerves control movement. So let's say you're taking the train. Okay, so the train is going to be your vehicle. The railway, the train railway is going to be your pathway. And then you're going to switch trains. So you've gotten one message to the nerves. You took a stop, took it to the brain, and now you're getting on a different train, which is your motor nerves, to control your movement. Does that make sense? How that's broken down? Kinda. Okay. Now, our spinal cord acts as the relay station. They're passing signals from the nerves to the brain. And of course, once it gets to the brain, we've got to our stop. We sent over the information, and now we're able to interpret pain signals and create this sensation of, ow, this hurts. Okay. Again, pain begins when nerve endings detect a harmful stimulus. In one of the other courses I teach or taught at CBD, we talked about a condition in which a patient can feel no pain. And I would always ask them, what do they think about that? Could you live a life with no physical pain? And I would get mixed reactions. And for me, I know that I need pain, and hear me out. Without pain, you're not going to know when something's broken. And so there is a condition where there are individuals who are born without pain receptors, or not pain receptors, but they can't feel pain. And they're always in the hospital because they don't know when they have a broken arm or broken leg. They can be cooking and mistakenly stick their hand straight onto the burner and not feel it. So it's kind of like they have no pain, but then they have to be extra careful because they're not going to be able to feel when things are broken. And that's because the nerve endings cannot detect that harmful stimulus. Now, sensory nerve transmission is so important. Signals are sent through sensory nerves, of course, through the spinal cord. And the spinal cord processes the signals. And what it does is it triggers a reflex response. So for those patients who can't feel pain, there is no reflex response. Thus, they can have their hand on a hot burner and not know it. Once the signal reaches the brain, that is going to be where the pain is recognized, and then the hand moves away from that burner. So, with systematic anesthesia, this is going to affect the entire body rather than just a specific area, regional, or a site, which is local. You may see these terms again. But how does it work? It prevents the brain from interpreting pain signals from anywhere in the body, kind of cuts it off. It's going to be ideal for surgeries that have multiple sites or areas that are hard to block regionally. Let's say we're doing a laparotomy where we're doing a huge belly incision. You're not going to be able to regionally block parts of the belly, especially if the incision is starting by the sternum and going all the way down to the pelvis, right? Like that, it's going to be almost impossible. Examples: skin grafts. Especially with skin grafts, we usually do multiple sites. One site is going to be the donor site. It could be usually the patient's own leg. And then the recipient site. Let's say they're a burn victim and they had a burn on their upper arm. So there's two sites, right? Breast reconstruction or autologous bone grafts. Now, systemic anesthesia, just make sure that there's a complete pain control, especially in these complex or widespread procedures. With different procedures, okay, we look at factors. We consider the patient's age. The amount of anesthesia you give a 2-year-old is going to be a lot different than the amount of anesthesia you give a 30-year-old versus an 89-year-old. Okay. We also look at cognitive ability, mental state, and emotional readiness. Patient preference actually matters, especially if they are very fearful of needles or are anxious. A lot of times those patients will be given gas before we our circulator places the IV in them so they can get their fluids. Okay. Keep in mind, general anesthesia, just make sure that patients are comfortable and it meets the needs of these crazy complex procedures that pretty soon you all will be in. Now, I mentioned that in like smaller surgery centers or like offices, you may be required to kind of help turn over this machine. Do not be intimidated by it. Okay. Now, this is what is called the anesthesia workstation, and there's a lot of components. Okay. Most likely, what we are usually responsible for in these smaller facilities is kind of like changing out the tubing, wiping down the counter, and then grabbing extra. We don't put anything in, but we'll grab extra vaporizers or different flushes and just kind of place it on the cart for our anesthesia. Okay. Now we're doing that in between cases because a lot of times anesthesia leaves with the patient, with the surgeon, with the circulator. And while we're already turning over in these smaller facilities, it's really quick to kind of grab that stuff, switch it, clean it off, and keep going. There are key features that you have to know. Alarms alert when readings go beyond preset limits. There are goals for general anesthesia. We're trying to prevent awareness during surgery. We want to have analgesia, which is block pain. We do want the patient to have amnesia. That prevents memory of the procedure. And we do not want them to be getting up and moving during the procedure. And so we want them immobile. Each component, each goal, it all works together to really help manage anesthesia during our surgeries. Now, we look at if the patient's aware. There are some cases where, let's say we're doing a craniotomy. I know you guys have seen like videos where the patient's kind of awake during craniotomies. And the first time, if you get the opportunity to do those cases, it may kind of freak you out a little bit, but there's a reason. When we're in the cranium, there's certain spots that we want to make sure we do not injure. And so we may have the patient, if they play like a guitar, an instrument, play that, or say certain things so that we know where we are in the cranium. Okay. Now, the different methods. This image kind of summarizes it all. IV or intravenous, where it's directly into the bloodstream. A lot of times, especially for little ones, they're going to inhale the gas. And that's going to be through a mask. With children, we kind of like have it a little bit away and they kind of breathe it in, or a tube. There's also balanced anesthesia where it combines both. You'll have an IV and inhalation for just the best effect for the patient. But there is a less common approach that the chapter talks about. Now, a regional block may be used with a light general anesthetic. This is going to be for those high risk patients. Okay. Now, this approach is rare, so keep that in mind, but can provide additional safety in certain cases. Now, this is really important. I have seen many concepts on a couple different finals asked a couple different ways with the phases of anesthesia. So you have 5. Pre-induction. This is the preoperative assessment and patient preparation. We're getting the patient in. We haven't really done much yet. Okay. Just kind of getting them from the wheelchair to the bed, having them walk in to the bed or from a gurney to the bed. We have induction. This is when the patient is receiving the anesthetic agent to make the patient unconscious. So this is the beginning. Okay. Patient goes to sleep. Then we start gowning, gloving the surgeons, draping, prepping, timeout. Okay. Now, maintenance. If you think about it, we want the patient stable throughout the entire surgical procedure, right? So with the maintenance phase, all anesthesia is doing is keeping that patient stable and unconscious during surgery. There are going to be some providers, believe it or not, that when they're inducing the patient, they prefer it to be quiet. And we'll talk about excitement in a second. And in emergence, this is when we're starting to gradually wake the patient. The anesthesia is starting to wear off. If you're in a case and let's say a resident or a fellow is closing, sometimes anesthesia will start to wear off that anesthetic so that that resident or fellow sutures just a little bit faster, and you'll know when it happens when you're in those cases. And then recovery is the post-operative phase where the patient recovers in the PACU. Again, that's going to be facility based because at the children's hospital, we recover our little ones in the room and then take them to recovery. At the children at the surgery center, we recover them in the PACU. At the other hospitals I work with, we recover them in the PACU. So let's break these phases down just a little bit more, starting with pre-induction. Again, patients coming into the room. We are looking at the patient's health, the readiness. They're getting them physically and psychologically ready. They're coming into the operating room by whatever means. If it's from the ED, they could be walking in, they could be, like I mentioned earlier, rolled in on the gurney or even a wheelchair. Or if it's a little one, we bring a crib or they'll be carried in. The patient is going to be given extra oxygen before anesthesia. Now, this happens simultaneously as you're setting up, okay? A lot of the things that we do in the operating room is simultaneously happening, meaning the circulator is not waiting on you to set up your room. The surgeon's not waiting on you. Everything's happening at the same time, okay? Now, pre-induction sets the stage, okay? We want a smooth transition to anesthesia. With induction, again, they're getting their medication. It is now being initiated by the anesthesia provider, whether it's a CRNA or an anesthesiologist. And again, this stops when the patient has reached an adequate depth of anesthesia and their airway, that's important, is secured. Okay, because you don't want anything to be moving, for anything to pop out, or the patient to go into laryngospasms. How do we put these patients to, I don't want to say to sleep, but how do we get them anesthetized? Um, Mask. Place the mask over the patient's nose, the mouth. They get the oxygen, they get the inhalation agents. This is going to be for those shorter procedures like ear tubes, where those cases are usually about 10-15 minutes. Um, it takes you about 10-15 minutes to set up. The case is about 10-15 minutes, and that's it. So it's not going to, patient's not going to be under a lot of anesthesia. Okay. But it does support respiration during surgery without kind of putting that patient to sleep because the case is so fast. We have the next one, which is, oh, I don't have it up here, the laryngeal mask or the LMA we talked about. It sits on the larynx, delivering oxygen and anesthetic gases. These are again for short procedures, particularly in like the ambulatory surgery centers. Um, it's not recommended for oral surgeries, a patient that's obese, hiatal hernias, GERD, or low pulmonary compliances. We have our ET tube. This provides the maximum air control. And this is going to be the one that you're going to see most likely in your surgical procedures. Why? Because this is used for longer surgeries. The patient is going to be deeply relaxed. Their muscles are going to be so kind of like flaccid. They're not going to be moving. And the patient is the position that we can usually put this patient in are going to be prone, meaning they're going to be on their belly. So I want you to think spinal cases, either ortho or neuro, because they both do back cases, or lateral positions. Lateral could be anywhere from general to ortho, emergency, transplant. Okay, so they're going to have the whole gambit. Now, The ET tube provides precise control for the airway management in surgeries with those longer and more complex positions. So, how does it happen? Well, a short acting muscle relaxant is going to be kind of given to them just to kind of make it a little bit easier for the tube to go in. Now, they are visualizing the whole time. If you have an opportunity in the operating room, let's say you are a floater, it's really cool to kind of, if anesthesia allows you to kind of see, because sometimes they'll let you see these are the cords this is what you need to do. Now, they are going to insert through the patient's mouth into the trachea. They're going to check for signs of proper placement. A lot of times they're oscillating and they're looking for chest rise and fall. Oscillating means they take their stethoscope and they're listening. Okay. Then they're going to measure the CO2 levels to make sure that, okay, we're in the right spot. Again, they're listening to both lungs sounds to make sure that it's properly positioned. And you can kind of see how it looks here, how it's going through. Now they're going to be looking with the LMA that has a light on it to make sure they're going in the right area. Okay, so that's the first half. The second half, we have to talk about maintenance phase in the surgical procedure. So now we're taking it to the next level. Like we've already got the patient in the room, they're set up, anesthesia's in, but now what? Our case is going to start. We're going to look at the emergent phase as well as major categories of anesthesia medications and intravenous induction agents and their purpose. We're not done. There's a lot. Um, we're comparing opioids that are used during analgesics for like general anesthesia, the different inhalant agents, their purposes, neuromuscular blocking agents, as well as comparing and contrasting depolarizing and non-depolarizing muscle relaxants. And then we're going to finish it up with the reversal agents because let's say something happens and the patient has a bad reaction. We've got to be able to reverse whatever was just placed in, right? So the induction phase, we know the patient is most sensitive. This is going to be those times where you may hear an anesthesia say quiet on set. And that's because for them, maybe they know something that we don't, right? The patient may be highly startled. And patients are highly reactive to noises during the induction phase, and they can experience a little bit of agitation, or some may even be excited. So it's going to be important for us and really the entire team to, when we hear that quiet on deck, or if you notice everyone's getting a little bit quieter, no one's really talking, because at this time, any sudden movements during this particular period can kind of startle the patient. Now, why does this matter? Well, we're trying to reduce distractions. It's going to help prevent stress or any type of discomfort that the patient, as they kind of transition into anesthesia, may feel. So we're just being mindful of the noises and movements because we want it to be smooth and safe. Okay. And for us, it's really just making sure, like when we're setting up our instruments, that we're not being like super loud and, you know, to the point where we can startle the patient. So now our case is going. This starts when the patient's airway is secured and stable. It's going to continue throughout the entire surgical procedure. Now, anesthetic agents are going to be given like throughout the case. So let's say the case is scheduled for 45 minutes and here we are an hour and a half. Well, anesthesia is going to continue to give medication to keep the patient at a level where they're not going to wake up. Okay. We want to keep them unconscious. We want to keep them comfortable and stable throughout the procedure. Now, this phase just makes sure that the patient remains adequately anesthetized and stable throughout whatever procedure it is, from a craniotomy to a heart transplant to a cholecystectomy. It doesn't matter. Okay. Now, some patients may recall or have explicit memories of events that occur during surgery, and this is known as intraoperative awareness. This occurs in about 20,000 to 40,000 cases a year here in the United States. Patients with a history of substance abuse or chronic pain are going to be more likely to experience this. But why do you think that is? You guys can type it in or you can speak. Why do you think that these particular patients will be more susceptible? Think about their tolerance. So if you have a patient that's like 150 pounds, okay, and we usually say kilograms, but you guys will get to that in the operating room. So we're going to say 150 pounds. And they're providing the anesthetic for a regular 150-pound, let's say 6'3" individual. Now, the same patient, that's it, the same patient has had shoulder surgery. Maybe they were a football player, they've had hip surgery. And so they have built up a resistance. Like you guys said, they may be resistant, excellent, high pain tolerance. They've built up resistance. So what they would normally give to that 150-pound person now is not going to be as sufficient. Okay. With long acting muscle relaxants, commonly given during the maintenance phase to keep the patient relaxed. This is all about timing. Proper timing of muscle relaxation is going to help us keep the patient relaxed, but it's only as needed. That same case that I mentioned, 45-minute case, we're at an hour and a half. Let's flip it. We're scheduled for 45 minutes. We got in, we saw that there wasn't much to do, and now we're out in 20. Okay. Keep that in your mind as we continue. Now, when we're monitoring, the depth of muscle relaxation is checked with a peripheral nerve stimulator, and that's just to make sure that we're at the correct level. Muscle relaxants should last through the closure of the deep wound layers. If you caught what I said earlier, once the resident or the fellow has the suture, they're usually on scan, they're superficial. Give you a hint, they're usually on Vicryl or monocryl. Anesthesia may start to reverse some of the anesthetics because we're out of the deep muscle. We're superficial. Okay. Now, it's going to start to wear off as superficial layers are closed. And this gives time for the patient to kind of come back and regain normal muscle function at the right time. So that's why anesthesia may start to reverse it a little bit, you know, sooner, because we want those residents to become proficient with their suturing and kind of like keep it moving. Now we're at the emergent phase. And if anyone has ever seen the movie Awake, it was crazy to me because he could feel everything. He could hear everything. He was like one of those 21 to 20,000 to 40,000 individuals. He felt the knife. They were getting ready to do the rib approximator. Like he was feeling it all. And I think the only thing that you could tell is that he had a tear running down his eye. Unfortunately, I believe his anesthesiologist was drunk or what. It's Hollywood, but it was a whole lot of. Now, emergence starts at the end of a surgical procedure. Anesthesia agents are discontinued or allowed to wear off. The patient starts to wake up. The airway is going to be removed as needed. And then the phase ends when the patient safely is transported to the post anesthesia care unit or PACU. Now, there is some type of patient sensitivity, okay, during emergence. Patients are highly, again, reactive to noise and movement, just like they were in the beginning. We just have to be mindful when we're cleaning up, okay? If the patient is being extubated in the operating room. So that means we're still doing kind of like we did in the beginning. We're minimizing our noise, sudden movements, because again, we want the patient to have a smooth recovery. So extubation, we're removing it, okay? Patient's awake, they're stable. If needed, A patient can be given oxygen to provide just a little bit of, let's say their O2 sats are a little bit low, so we'll give them oxygen. The anesthesia care provider gives a detailed report to the PACU staff nurse about the patient's status. You may be required to transport the patient with the circulator with anesthesia to PACU or a step down unit. Let's say the patient has a lot of fluids. They have, just a lot going on. Their bed is huge. It's just additional help. So kind of keep that in the back of your head as well. Now, these are some considerations. The patient must be breathing on their own and able to maintain their airway independently before the ET tube is removed. That's really important. You may see that somewhere. Hint, hint. We get to the recovery phase. This starts when the patient is in PACU. The patient is fully awake from anesthesia and begins to actually recover. Now, patients' vital signs, they have to be stable before they can be discharged from the PACU, or if you're at a surgery center, home. The recovery phase is the final post-operative phase of general anesthesia. I will repeat that again. The recovery phase is the final postoperative phase of general anesthesia, and it focuses on monitoring and ensuring that the patient is safe and has kind of regained full consciousness and is stable. So we've gone through the case. We have patients been put to sleep. We did our thing in the operating room. The patient was maintained anesthetically. They were woken up. They were extubated, and they were in recovery. But there are different types of anesthesia medications. When we look at intravenous induction agents, these are the ones that are given at the start of anesthesia. Okay, propofol. Sometimes we'll give a Versed to kind of give them a little bit of amnesia. We have analgesics. They are preventing that pain sensation during the procedure. With our inhalation agents, we are kind of inducing unconsciousness and preventing motor responses to painful stimuli. And there's neuromuscular blocking agents where they relax the muscles for intubation and they help with all surgical procedures. Now, there is a 3-minute video that I'm going to share with you guys. It's going to be in the archive. So make sure you check that one out. Okay. And it's all about neuromuscular blocking agents, just a little bit extra. It's not going to be anything that you would see on the final or the quiz, but something kind of fun to kind of look at. We also get to reversal agents. Reverse, or they're going to counteract the effect of other anesthetics to assist in recovery. Now, all of these medications contribute to just helping the desired components of what we need in general anesthesia. And it really does help the patients remain unconscious, pain-free, and relaxed. And that's really what we want during all of our surgical procedures. So we have sedatives, okay? Hypnotics that help for induction. Examples, I think I mentioned Versed already. Valium's another one. They are given to calm. Like a patient's really, really nervous, they're going to get Versed. That's usually the one you're going to hear a lot. Versed's on deck. They may get Valium, but Versed's the one. We also have hypotonics or barbiturates, pentanol, Brividol. What these do is induce unconsciousness by going in and depressing the central nervous system, kind of like slowing it down, okay, pushing it back. There are other hypnotic agents. Ketamine we use, or you'll hear in the operating room. And this is one that I'm pretty sure everyone's heard of from Michael Jackson, which is Propofol. Okay. Propofol is the most frequently used agent for induction. I will repeat that. Propofol, which is a hypotonic agent, is the most frequently used agent for induction. It has a milky white color. And the thing to remember with propofol is anyone that has an allergy to like soy or eggs, they have to avoid propofol because the substances, eggs and soy, are actually part of the emulsion and the fluid. Okay, so then they would probably give like ketamine or something different. Again, all of these agents help induce unconsciousness. With the chart, I'm going to provide the chart as well in the archive area, just so you guys can kind of have it. Um, these are opioids. Okay, morphine. We do use codeine and cocaine, believe it or not, in the operating room for different things. Those are our natural opioids, is morphine and codeine. Our synthetic opioids are going to be fentanyl, sulfatina, Ultiva. Now, opioids are administered during the maintenance phase. So surgery is going on and they're just trying to keep the patient stable. Okay. And it's to help prevent pain and just make sure that that patient remains comfortable throughout the procedure. Now, these drugs are commonly used because of their morphine like effects, which helps kind of maintain that pain free effect. Okay. So the inhalation agents, like I mentioned, you're not going to replace these in the machine, but you may grab them for the anesthesiologist. Again, it's going to be based on the facility. A lot of the hospitals have anesthesia techs, and so they're grabbing all that. But again, I just wanted you guys to be aware if you find yourself and they're like, "Hey, go get me some isoflurane," and you're like, "What?" Um, they that's why, like if you're in a smaller area. Okay, so types of inhalation agents, you see them in front of you. Nitrous oxide, most widely used inhalation anesthetic. We have some volatile liquid anesthetics, which is the other three, isoflurane or fluorine. You're going to hear isoflurane. There's desiflurane or suprane, and then sevoflurane. Okay. Now, these volatile agents are going to be stored in liquid and then they're kind of poured into a vaporizer, and that's going to convert into gases, and then that's when the patient inhales it. Um, with a MAC, okay? Minimum alveolar concentration. I know it's going to be kind of hard to make sure we get them, but like I said, again, you're going to know by the way the question's being asked. This measures the potency, like how strong of the inhalation agent by the concentration needed to stop motor response for surgical incision in 50% of patients. So we go back to our 150 pound patient that has a higher tolerance. He may need a higher concentration just to keep him stable while he's under anesthetics. There are some disadvantages that we have to talk about. They can cause a decrease in heart function. They do not provide pain relief after surgery, and that requires additional analgesics or additional pain meds. The choice of inhalation is really going to depend on factors like solubility, how solid the gas is, and really how strong that patient's heart or cardiac output is. Okay. But these agents are so important for maintaining anesthesia, but must be carefully chosen because we want to minimize side effects and just make sure that it's like we're having effective patient management. Again, another chart of neuromuscular blocking agents. All of these agents are used to kind of relax skeletal muscle during intubation and throughout the procedure because we really want the patient to remain still and immobile. So we're looking at types of tissue, cardiac, smooth, and skeletal. So it's working on all of them. And what happens is while the patient's under general anesthesia, again, their skeletal muscles may actually still respond to stimuli, okay? Especially in neuro cases. They're responding to stimuli. So with neuromuscular blockers, this is going to prevent this by relaxing that muscle as well. For muscle contraction, stimulation from a motor nerve is going to be required. So a lot of times when we're doing microdiscectomies where we have the microscope, they're going to be hooked up to neural stimulants. And so the there's like a person that comes in too and they're monitoring that and they'll let us know, hey, whatever you just did, this nerve isn't functioning or this one just kind of snapped. And that kind of helps us to determine, okay, This is where we're at. This is what we need to do. Okay. Now, there are types of neuromuscular blockers again. Sucks. This is going to be the one you're going to hear the most about, succinylcholine. It mimics acetylcholine. It has a longer duration. Okay. It is a depolarizing neuroblocker. The other ones that are up here are, as you see, they are non-depolarizing. Now, how do we choose between a depolarizing or non-depolarizing? Well, we're good because we're scrubbed in. But the anesthesiologist is going to look on pharmacological properties like the duration and the action of the onset, like when it's going to start to kick in, looking at the case and kind of figuring all that out. Reversal agents are really important because they're going to counteract the effects of specific anesthetic agents, especially when the surgical procedure ends earlier. So we go back to that 45-minute case, we're 15 minutes in, the surgeon's like, stitch, and you're like, what? Yes. We're excited, but now anesthesia has to kind of like really work, right? Because now they have the patient set for 45-minute unconsciousness. And here we are at 15 minutes monocryl. Okay. Like we have bypassed all the others. Like we're golden. They're getting ready to do monocryl, which means we are almost done. Okay. So you have Narcan, we have Revex, we have Trexcan. These agents are going to reverse the effects of opioids. We have benzodiazepines like amazicone. This is going to reverse the sedative effect. And then we have non-depolarizing muscle relaxants, again, that are going to kind of reverse or help the muscles recover their function. Okay. Now, these are going to be really important, especially for our anesthesiologists or our anesthesia providers when the procedure is a lot shorter than is expected. And now we're ready for this patient to start waking up. Not a long chapter. Why do I say that? We're about to do another mini session bell. Here we go. Which of the following is the first and most reliable sign of malignant hyperthermia, MH, that healthcare providers should monitor for during anesthesia? Okay, so everyone has typed in tachypnea, which is rapid breathing. But I'm going to explain why that's not going to be the first thing we look at. Okay. Now, tachypnea is a sign of malignant hypothermia. That is 100% correct. It occurs as the body attempts to eliminate all that extra CO2. Okay, you guys get where I'm going? So CO2 goes up first, then rapid breathing starts to get rid of the CO2. This is why I picked these two choices because these are two that are like, wait, we know that the patient's going to start breathing more rapidly because it's trying to get rid of the CO2. However, the increase of CO2 is what causes the rapid breathing. Does that make sense? Okay, because you may see this. So yes, Anna is correct. So it is B. Now, again, I chose this one specifically because both of these are signs of malignant hypothermia. It's just now we're putting it into which one is first. We're having rapid breathing, but why? Well, the rapid breathing is happening to get rid of the CO2. The CO2 is there because it has increased. Okay. Next question. Which of the following is a key role of the surgical tech during the management of malignant hypothermia? A, administering dantrolene to reverse the effects of malignant hypothermia. Or B, assisting with oxygen, cooling the patient, and preparing medications for the team. Yes, we are going to assist with oxygen administration if need be, cooling the patient if need be, and kind of helping with medications if need be. That is our role. Okay. We just have to really be familiar with like emergency medication and equipment to act quickly and support the team in managing this extremely medical emergency. Now, dantrolene, you're going to hear a lot, and I'm so proud of you guys because dantrolene is the medication of choice for malignant hypothermia. You're going to see this question from here to the CST exam to when you guys are doing drills in the operating room. What's the drug that we get for malignant hypothermia? You're going to know it in and out. It is dantrolene. However, it is the responsibility of course, our anesthesia team and not us as the ST. So I'm so proud of you guys. So good job. Just like on Monday, for those of you that have already completed the survey, go take a break. For those of you who have not had the opportunity yet, I wanted to give you guys the opportunity to take the survey. So I'm going to go ahead and put it in the link. If for some reason it's not working from the link, just remember that if you go to week 10, it'll be there as well. I tried to copy and paste the link for you guys. So if it didn't copy over, that is why. But 5 minutes and we will be back. All right. As we are finishing up, what questions do you have for me before we get into our quick little Kahoot? What questions? None so far? Okay. No pressure either. Um, we have a little Kahoot game. There are 10 questions, 5 true and false, and 5 multiple choice. And I was seeing if I had done 2 choices for the multiple choice, and unfortunately I didn't. So if you are able to log in, let me know. I know 2 are not going to be able to log in. Okay. And I love that. So if you're not able to log in, you can go ahead and log in on chat too, whichever is easier for you. Okay. Okay. And I'm not sure, full transparency, if I changed it back to 20 seconds. So if it is 5 and 10, I apologize in the beginning. Okay, with 5, that is enough. Everyone else can actually kind of type in if that's easier as well. All right. Okay, 7. Awesome. Let's go ahead and get started. Get you guys in and out. And this way you guys can have it as well. Okay, so I did go back to 20 seconds. Perfect. Sucks. And I'll probably you'll hear me using the regular term we use in the operating room. So we don't usually go around saying succinylcholine. We'll just say sucks. Okay. Good job. Nitrous oxide. That is true. Good job, everybody. So remember, increased risk of cardiovascular depression. Good job. It is true. Another true or false question. True. We're talking about non-depolarizing. It is pancuronium bromide. Pancuronium bromide. You guys are on point. Yes, that's true. It's actual propofol. So most commonly used for induction. Remember, um, easiest way to think is Michael Jackson. That's how I always remember that question or that concept when it comes up. Plumazanilin. I think I said that correctly. And the last one. And it is false. So I'm going to share this again. This will be in the archive area so you guys can kind of go over it just as another resource, not just for this quiz, but for your final. Okay. Also for your final. Good job. Good job. All right, I know we're a little bit over, so I'm gonna make this really quick. We talked about general anesthesia from every aspect, from the phases to the terms to how our job kind of goes with the whole entire team. For those of you that are watching this playback, how do the properties of inhalation versus IV anesthetics affect anesthesia management? What steps can the surgical team take to prevent awareness under anesthesia? And how could improvements in neuromuscular blockers benefit high risk patients? You guys, I, I'm like at a loss for words. We're already at week 10. I feel like it's gone by so fast. We have one more week together. I do want to thank you all for just being here this evening from work, from life, because life is lifing. I want you guys to have a wonderful rest of your evening. Have a great rest of your week. Y'all, please be safe this weekend, whatever you do. I do look forward to seeing everyone who is able to attend next week, week 11's last session. Good night, everybody.